Welcome to Module 4, Posterior Pelvic Tilt. The next concern we're going to address is a posterior pelvic tilt. This misalignment is less common than the anterior tilt, but it comes with its own set of challenges. And, much like the anterior tilt, leads to a decrease in performance and can lead to pain or injury. A posterior pelvic tilt is sometimes referred to as sway back hips. It's associated with shortened and tight hip extensors, especially in the hamstrings. It's also associated with weak, inhibited, or over-lengthened hip flexors. Many times, the posterior pelvic tilt goes unnoticed and unaddressed. This occurs mostly because people don't know to actually look for it. The pelvis normally has a slight forward tilt, about 5 to 10 degree difference between the PSIS on the back of the pelvis, which is the higher landmark, and the ASIS on the front of the pelvis, which is slightly lower. In a posterior tilt, the angle is significantly less or even flat. Although it's called a posterior tilt, it's important to note that it doesn't actually tip the pelvis backwards. It's just tipped back more than normal, the 5 to 10 degrees. This means you could have a 3-degree pelvic tilt with the front of the pelvis being lower than the back, but we would still consider it a posterior pelvic tilt because it may be dysfunctional or pain-producing. The example above is a typical posterior pelvic tilt. You will notice that the tester has their fingers landmarked on the ASIS on the front of the pelvis and the PSIS on the back of the pelvis. You may notice that there is not much of a noticeable difference in height between the two landmarks. Function testing of the hip stability confirmed that the pelvis was tilted too far posteriorly for proper muscle function. It's important to note that it's difficult to eyeball or observe a posterior pelvic tilt. Sometimes individuals with this alignment will have well-shaped glutes, so it may visibly look like an anterior tilt, but upon closer inspection, it will show that it's not. Many clinical referrals for chronic hip and back pain have been posterior pelvic tilt patients that were inappropriately identified and treated as an anterior pelvic tilt case, simply through observation and assumption by some other healthcare practitioners. It's critical that you test with your hands on the subject in order to find out for sure. You have to find it to fix it. What are the causes of a posterior pelvic tilt? This misalignment can be caused by an exercise routine that is posterior chain dominant and can leave the hamstrings tight and shortened. Another cause could be inhibition of the hip flexors. It's possible this could be due to hip flexor strain or even overstretching the hip flexors. The psoas is tied into the diaphragm, so improper breathing patterns can also lead to an inhibited psoas because it doesn't get the regular muscle activation that would be present in a normal breathing pattern. An excess cervical curvature can also lead to a compensatory posterior pelvic tilt. This is a means to reduce neural compression. It's important to consider a neck assessment or refer out for an examination of neck posture. Additionally, it's believed that long-term adrenal fatigue may inhibit the psoas. Much like the anterior tilt, compression of the lumbar spine can lead to improper innervation and cause this misalignment. Another possibility is that high arches or bow-legged posture may shift the center of gravity posteriorly in standing. So clients with high arches or bowed legs may tilt the hips back as a compensation. There are many different possible underlying causes of a posterior tilt. It's important to investigate the possibilities so that we don't recreate the problem after we've resolved it. When a client has a posterior pelvic tilt, there are a few concerns that come along with it. The first is that it compromises the angles of the lower limbs, which can alter function and lead to a decrease in stability and performance. It can also reduce or remove the natural curve in the lumbar spine, as you can see here. This can cause excess spinal pressure and impact the nerves that innervate the lower body. A posterior tilt can inhibit muscle activation and decrease client performance. And if the upper body is stacked on an unbalanced lower body, it can lead to dysfunction in the upper body as well. Everything is connected and the pelvis is the center of the body. Derangements here can affect length-tension relationships, even center of gravity distribution in the rest of the body.
For posterior pelvic tilt, you want to do a thorough assessment. Don't just eyeball it because a lot of times visually somebody can have full glute shape but have a posterior pelvic tilt. It can be very deceiving from a visual assessment. So what you want to do is compare the differences in height between the ASIS, the bony bump on the front of the hip, and the PSIS, the bony bump on the back. So Monica here will find the ASIS feel like a little bony knuckle, and if you're having trouble finding it, you can have the client bend forward so you can relax the muscles and hook underneath, or you can have them lift the knee up and down, and then that'll help you hook underneath to find that landmark. The PSIS will be the little bony bump by the low back dimples. You can make a peace sign to the low back. That'll generally put you in the right vicinity, and you can feel around until you find it. If you have difficulty finding it, you can have a client lay on their side, and that will slacken all the muscles around the low back so you can feel in to find that landmark. So you want to compare the height differences between these. Now, normal would be about 2 finger widths distance in height, like this. In a posterior pelvic tilt, you're going to find it's about 1 finger or less, okay? So it'll look similar to that. But we want to have some sort of functional confirming test to show that there is a problem there. So we're going to use the lying hip swing test. I'm going to have Monica laying face up here. Typically with a posterior pelvic tilt, we're going to find a lack of stability in the hips during this test. So I'm going to have her non-test leg up against the inside of my ankle. I'm holding this leg out to the side. Don't let me swing in. You're going to find it's going to be very weak and compromised. If you ask them to score it on a scale of 1 to 10, they're probably going to give you a number below a 7 out of 10. Then what we want to do is put them into an anterior pelvic tilt. There's a couple different ways you could do this. You could actually have them manually tighten up the hip flexor, so just press that with your hands. So just take your hands and press right down to tighten up the hip flexor, make a curve in your low back, then we retest and go, boom, and you might notice an immediate improvement in strength. And what you want to think about is you want to imagine that the gears in the hips aren't lining up because of the posterior pelvic tilt, but then when we do these modifications, tightening the hip flexor and anteriorly tilting the pelvis, all of a sudden everything can engage and you'll notice an immediate improvement in stability. If they have a painful movement, a squat or a lunge, you can cue these movements and see if that reduces pain. In addition, sometimes people with posterior pelvic tilts will report that they get pain at the bottom of the tailbone when they've been sitting for long periods of time because the coccyx is jabbing right into the seat. So these are some different indications that your client may have a problematic posterior pelvic tilt.
Let's take a look at a corrective exercise case study of a posterior pelvic tilt client from our exercise therapy certification.
Big hand to Hamid. With massive biceps. Okay, so what is the posterior pelvic tilt? It's exactly the opposite. When the PSIS is basically lower and it's almost into a flat line, right? So I had a chance to basically test Hamid and take a look at to see what we found in terms of position of ASIS and PSIS, and he was more into posterior chain. But remember, one of the most important assessments is personal pain movement, right? So can you tell me about the personal pain movement? So knee pain on the right side as you do single leg squat. Okay, so can you show me exactly where you start to feel it? Okay, so I get a good idea of, I don't want to do it again. I get a good idea of where he's going to have the pain when he does this, right? So this is more powerful than any assessment for me. If I can basically do a corrective that it can help him, that's more important than anything else, right? And he said when you do a straight leg raise, you feel low back? Yes. Okay, so we're going to test both of them, okay? Is it 100% that when we do correctives, these are going to get fixed? No. But if it's related to his posterior tail, we should be able to make it an improvement there, right? Can you lie on your back and let me know where you start to feel the low back? And again, don't try to push after. So I just want to know where it starts. Okay. So we get as far as about close to the knee, he's going to get a low, bring it back. as far as close to the knee, he's going to start to feel low back pain. Okay. So what would you score that pain? So 4.5 score of pain on the back. And what was the pain score on the knee? 6. So we had 6 pain. So these are significant to know. Okay. Now, if I would take a look at what we have in terms of structural assessment and function assessment, it was this side, right? So can you turn facing this way? So here's how we test the posterior tilt, right? So we'll find the ASIS right there, and we're going to PSIS, the dimple. So you hold your hands up. Can you guys see it's a lot more in the flatter line? So maybe just a half a finger difference. You see that? Okay. Now can you show you the other side as well? So what I saw over there is that there's a little bit of a difference in both sides. Yeah, you can see this side is higher, right? And it didn't have any pain here. So I'm gonna put majority of my focus on that right side, and we're gonna go through the correctives and see if we can actually make an improvement, right? In most cases, if I see a function problem on both sides, I would use both of them, right? The other thing that you had was when you're testing on a line, what was the one that helped the posterior? Tightening up the hip flexor, right? So can you line it back? So these are all confirmations that I know this should be a corrective for him. Okay? So this is the side that he has a knee pain. So resist to me as hard as you can and go. Right? Now hold your hip flexor. Just put your hands right in your hip flexor. Resist to me and go. You can see there's a lot of ways that we can confirm that this is a posterior tilt. So it's ready for us to basically go through correctives and see what we can do. Okay? So let's go through it. Now here's what I know about posterior tilt. A lot of these exercises, first of all, posterior tilt is a very stubborn position. So like it takes a little bit longer time to be able to bring someone back. So a majority of them we're actually going to put a lot of endurance in the thing is. So we spend more time in each exercise when we go through it, right? We're going to try to do it quickly based on the time, but I'm going to go through all of the movement with him, right? So we'll basically judge it based on the dosage. So first one I'm going to get you to do is a gap settle calf stretch. So it looks like this. You're basically on a downward dog position like this, and you're just going to drop one heel down, so you're stretching the calves, the other one's going to bend, hold about a 5 second, and then switch it the other side. So keep your hips as high as you can. Okay? So bring your hips up, hips up, hips up, hips up, hips up. So I'm going to try to get hips as high as I can. Now bend this knee, drop this calf down until you feel a good stretch, couple of seconds, and then switch it. So try to keep the hips up. Now why I say hips up and hip down, that not only I can actually get that line of muscles to be able to stretch and get a bit of a nerve flossing, as well as I'm getting a bit of a decompressions and spinal inversion in here as well, right? So it's good for basically getting everything working together. And then each time my basic cue to him would be to not drop your hips. So you have a tendency to go into that side, right? So as he's basically going through it, we're going to do about 5 seconds, alternate, go to the other side. And this is a powerful one. We saw it in a quad, basically high kneecap as well, right? So there's a lot of basically factors that this can help someone with a posterior tilt, as well as you see how much of a stretch we can get in, especially knowing that he had some low back pain in here as well. Okay, so once he gets about a 10 to 15, that's what I said. Like I would probably for him I would have stayed until like 15 to 20, but I'm just gonna base on the time. I'm gonna go a little bit faster. We'll see if we can actually make an improvement on that. You good there? Yeah. Okay, so next one I'm gonna do is, if you remember on an anterior tilt, we had the toes out when we're doing a hip flexor stretch. So I'm going to get you, especially on that side, to do it, but you're going to turn your toes inward. So basically, I'm going to be in a hip flexor position, turning the toe inward, squeeze the glutes, and then move your hips forward. So you want to feel the tension in here, right? So once you get so that was side of the right? There. Turn the toe in, squeeze the gut, squeeze the butt, move forward. Basically, that's how it's done. And then hold it for a couple seconds and come back. Even for him, I would say just hold it. Go for 30 seconds and just hold it. Keep your head up and then upright and then keep doing it. Because I want that tension to stay. Now, what are we doing? So anterior tilt was a psoas that we want to release. In here, it would be iliacus, right? So most of people basically see it as a full complex of iliopsoas. They actually work against each other. So psoas is the one that basically pulls your spine more forward in anterior, and iliacus is the one that basically pulls you backward, right? By changing the position of the feet, you're putting a lot of focus on a specific muscles that you wanted to release, because that's the one that basically holds a lot of tension and is pulling the spine more into that posterior tilt. Okay? So I will get him to basically do it by this specific cueing of turning the toe inward. Okay? So once he gets about, let's say, at 1 to 3 repetitions, I'll hold them until about 30 seconds. I want to give as much as I can to that stretch. So getting that basically tension and releasing the tensions on there. And if I wanted to give him a little bit more progressions or open up more, I might just get him to basically push this hand up straight towards the ceiling as he goes, so I can get those connective tissues and fascia lines, everything to basically open up as well. I think he's good there. Now, next one I'm going to get him to do is, we know that tightness in posterior tilt for people that they're basically sitting in here, they're most likely they're going to have hamstring and posterior tightness, right? So I'm going to give you a hurdle hamstring, okay? So loosen up the hamstring and releasing posterior tilt. It looks like this. So basically, I'm going to get you to put that leg forward like this, cross this leg back, put the hands in here, stretch as upright as possible, and then you're going to try to basically, without rounding your back, you go as close as you can forward, and then until you feel that tension in here, right? So some people, they're just here, I can't even move. Just watch, do not let them to turn their head and spine forward, right? So if this is basically his range of motions, that's what I want. Like, I want him to feel the tension, and I might start to give them a little bit of like this. For example, push the foot down to the ground, a couple of seconds, 1, 2, 3, and then relax and see if you can go further down. Okay, almost like pushing down to the ground, 1, 2, 3, relax and see if you can go further down. And then my cue is always head upright, just like this, and go forward, right? In a lot of posterior tilts, I always watch the head as well. Think about your body. It's like if someone is posterior tilt, for my body to stabilize myself, right, their head is going to go in like this, right? So a lot of cases we see like people that are posterior tilt, they're going to have that neck curve a lot as well to try to balance their body to not fall, right? So it's good to cue that, to basically keep a good upright posture, right, when you're basically cueing them into work practice. About 30 seconds of holding it. Like a lot of them, I wanted to basically put that repetition in there. We doing? Good? His veins are popping out, that means this is working hard, so I'm okay with that sign, basically. Okay, so next one. Now, while all we did was releasing all the muscles that they were tight, it's time to basically put stability back and try to basically hold them in that right positions, right? Next one I'm going to get him to do is going to be a hip flexion isometric, okay? So this is basically, looks like this. I'm going to get him to basically go on the ground in a 90-degree, toes flexed, and I'm going to push to your hands and hold this for about 30 seconds and relax. And I'm going to get you about 3 repetitions. So hold it 30 seconds, push toward here. So what he's doing is he's trying to basically create a little bit of a tension back to hip flexor and psoas. What did we say? This was what it made him strong. So I'm going to put that tension back in his body, right? And as well as basically anterior rotation. So start to move the hips in the right places. So I might get him to basically do even 60 to 90 seconds of push, if I wanted to put a lot of tension into it. Like, we're just going based on time. But that would be a really powerful one for him to do, is because I'm constantly putting the pressure on where, by even holding, he was getting strong, right? And he's turning a little bit red. You good there? Yeah. Okay. Keep doing. Now here's what I want you to know is, what is this angle? It's the angle of most people, they can't even get there, right? So like, if you take a look at posterior tilts, guys, like basically when they do it, this is the ones that they get stuck in here and can't move, right? So hamstrings are tight. So most likely they're not even using this range of motion, right? By adding this range of motion is I'm putting in a place that he's not used to even being there, right? So it can be very powerful for him because that's the part that must go weak. Good there? Just get up. And I'm going to give him a last one. Let me just move this stuff out of the way. Another isometric hip flexion is I'm going to get you to be in this place. Use this leg. And as you're going to lift it up with flexed toes. So I'm going to get him to basically go in here and then hold the 5 seconds, relax, come down. Again, go up, hold the 5 seconds, relax, come down. So this is more of a decompressed position for him to be. So I'll just basically hold him in this place, tighten up the hip flexors, tighten up the psoas, just giving him back what he basically helped him to create stability. Okay? And with tightening up all these things, what's going to happen? It's going to pull this spine a little bit more into a little bit more of a neutral or more anterior than what he is facing. Did I miss anything? No, tall spine. Just make sure you're not basically moving your body. I think we went through everything. Alright, are you ready to test it? Okay, so let's start with our pain movement, okay? We don't know if we made a difference, but I'm going to try, okay? So we had 6 out of 10 pain going to single leg squats, right? So can you try it and let me know how it feels? If it doesn't feel, you're not hurting my feelings. I just wanted to know.
Nice. Yeah, that was pretty.
It was good. No pain. So 6 out of 10 pain went to no pain. that fast, and we didn't even do those long times, right? I would have put him through more, right? What else we had? Pain movement. Let's try this. Can you go further? Do you have any pain? No pain.
Wow.
This is more powerful than even any function test that I did, because this was pain movement. This is what it gave him instructions, right? Okay, so for sake of it, let's try the functions as well. So lying in your back room, we're going to test the functions. So, Abe, what was your, I didn't even score him, to be honest with you. I'm just going to go with this strength. So that was my bad, but I'll test him to see how he is, basically. So push as hard as you can out and go.
Nice.
Strong, I'll take that, okay? Let's see what we have for Mohammed.
If your client presents with a posterior pelvic tilt, you want to avoid or consider limiting stretches for the front of the thigh and exercises that focus on posterior chain, especially hamstring shortening exercises, as the hamstrings contribute to a posterior tilt in a much greater degree than do the glutes. Let's examine these in greater detail.
If somebody has a posterior pelvic tilt, we want to avoid stretches for the front of the hip and thigh. Typically, these muscles are already in a lengthened position, and if we lengthen them further, we can add to the problem. Here, Monica is demonstrating a quad stretch with the rear foot up on the bench. Any type of quad stretch is generally not advised in this situation. Additionally, stretches for the front of the hip flexor stretches are best avoided. Often you'll see people doing a long lunge stretch in which they're loosening the front of the hip, and we want to avoid those as well, because with a posterior pelvic tilt, these muscles are already in a compromised lengthened position, so it doesn't make sense to lengthen them further. We're only going to make things worse typically. If somebody has a posterior pelvic tilt, we want to be careful with posterior chain exercises, specifically hamstring shortening exercises. One example is the Romanian deadlift or the top half deadlift. In this variation of a deadlift, you typically go about halfway down, then back up while doing a hip hinge. With full deadlifts, you do get some lengthening at the bottom, but a half deadlift like this, we would definitely want to avoid because it's going to shorten the hamstrings even more. Another example of an exercise we would want to be careful with is any variation of the hip bridge. Here she's doing a bent knee hip bridge with the feet on a bench. And once again, this is going to be shortening the fibers of the hamstrings more, which is going to be contributing more to a posterior pelvic tilt. She could have her feet on a Bosu ball, a Swiss ball. She could be doing this one-legged. There's a whole bunch of different variations. Probably not the best choice for a posterior pelvic tilt. And in addition to this, there are exercise machines at the gym that you will see that target the hamstrings, specifically the lying leg curl or the kneeling leg curl machine. These are probably best to limit or avoid completely if we're trying to promote more of an anterior pelvic tilt.
Now that we know what not to do, let's take a look at some of the great choices to include in a program for a client with a posterior tilt. You'll want to include hip flexor dominant and quad dominant exercises. This will help pull the pelvis back into postural alignment. Also, you can program exercises from a seated position on a ball or a bench. And lastly, exercises that help promote good neck posture. There's a strong link between a healthy cervical curve in the neck and presenting with a posterior tilt. Let's break these down a little more.
If somebody has a posterior pelvic tilt, it's a good idea to do more hip flexor focused exercises, such as banded lying hip marches that Monica is demonstrating here. Bring in the knees up as high as possible. You could even add isometric pauses at the top. Once again, we've got a mini band looped around the midfoot. An additional exercise could be V-sit reach backs, sitting on the tailbone, reaching one arm behind at a time, or any exercise from this V-sit position. Could be a Russian twist. Anything could help to bias the hip flexors and core, which is good for posterior pelvic tilt. And then a third exercise could be alternating leg raises, laying face up, raising the legs in a scissor-like fashion, alternating leg raises, keeping them off the floor, We're getting a bit of the core in here, a bit of the obliques, and a bit of the hip flexors. All of these exercises will help to tighten up the front end of the hips a little bit more and help to move the pelvis back into prime anatomical position so you can get the best results for your clients. It's a good idea to do some exercises that focus on the quadriceps. Specifically, any heel elevated variation of the squat can be beneficial. Here we're using hexagonal dumbbells so they won't roll away, and Monica's going to have her heels elevated and she's going to be doing a goblet squat holding the weight in front. So any variation of squat with the heels elevated is going to bias more of the quadriceps. And an excellent finisher is to do top half squats, where you only squat to the top half and then back up, and that'll burn out the quads at the top of a set. That's one excellent option for biasing the quads. Now, one of the things you could also do is a Swiss ball lunge with the ball against the wall. And with this variation here, she's going to have one leg all the way forward and one leg all the way back with the heel up. And she's going to have the front heel elevated, palms pressed together will help to activate the core, and she's going up and down. This variation of the lunge is going to bias more of the quads. You have to actually activate the quads more to push back into the ball up against the wall. So this variation of the lunge naturally biases quads. Having the heel elevated will bias quads even more. A third exercise option could be a Swiss ball knee-in. For this variation here, you'd have the front of your feet on the Swiss ball in a plank position, rolling the ball under and back. You could also do any of the quadricep exercise machines at the gym. Specifically, the leg extension machine is an excellent choice. You could do hack squats, anything like that that will help tighten up the quads is going to help promote more of an anterior tilt to help your clients get into the best postural position to help them achieve their goals. To help promote more of an anterior pelvic tilt, it's a good idea to do seated exercises, specifically seated right on the edge of the seat, making a little bit of a curve in the low back. Here, Monica is going to demonstrate the seated zombie curls with the palms up on the way up for the biceps, flipping palms down on the way down to hit some of the forearms. So you could also do an exercise like a front and side raise combination. Now you could also do a seated exercise on a Swiss ball. Either way, just maintaining this seated posture is going to bias more of the hip flexors. So if you're doing upper body exercises, this is a way to help us restore posture back to prime anatomical position. Sit on the edge of an exercise bench with tall posture or sit on an exercise ball. An additional consideration if somebody has a posterior pelvic tilt is to do exercises for good neck posture. Clinical experience has shown that posterior pelvic tilt often accompanies a step in the cervical vertebrae in which one segment has slid over another. And the theory is that the posterior tilt might be there to reduce neural tension. So this is an example of a wall lean exercise that's promoting a straight neck. You could do an exercise like this, but you could also do it with marching to help target the hip flexors in addition to working neck posture. So if a client does have a posterior pelvic tilt, we want to definitely be mindful of neck posture and potentially consider incorporating neck posture drills such as this here.
Next, we'll cover some programming hints for these posterior pelvic tilt clients. In the warm-up, use hip flexor isometrics. For cardio, running on a treadmill works well because it activates the hip flexors. In the program, start with hip flexor focused foundation phase, or even a burn phase, and program 2 to 3 sets of 60 to 95 second sets. You're going to want to follow that for about 4 to 6 weeks. After, progress them to the next phase. It's important to note that a posterior pelvic tilt client typically isn't as stubborn as an anterior tilt. An anterior tilt client may require 3 months of very specific corrective programming, whereas a posterior pelvic tilt client often responds to just a single corrective program before returning to regular exercise programming. On top of all that great programming knowledge, you should also try out the Yep Yep. This program was created and used by our head instructor, Brendan Fox. This program has been highly consistent in clinical setting for helping to reverse dysfunctional posterior pelvic tilts. It requires little more than a 55 centimeter Swiss ball and some dumbbells. It has produced breakthrough results for Brendan's clients at the medical clinic, and we're confident you'll be able to apply it with your clients with great success. Once again, treat it as a recipe from the master chef. You may need to modify an ingredient or two based on the unique taste preferences of your clients, but try to stick to the theme of the ingredient you're switching out. Let's review what we've learned. Although less common than an anterior tilt, a posterior pelvic tilt is a misalignment you will see with your clients, and you need to know how to program for it. It's a misalignment of the pelvis that's characterized by shortened and tightened hip extensors and weak or inhibited hip flexors. It can be caused by many factors, including a posterior chain dominant exercise routine, inhibition of the hip flexors, spinal pathologies, or due to high arches or bow-leggedness. If a posterior tilt does not get properly addressed, it can cause decrease in performance, pain, and injury. By utilizing the right exercises and avoiding exercises that could further dysfunction, you can set your clients on the right path to success.